So it's my great pleasure to introduce Professor Michael Sharpe, and I'll let him take over the screen and share his slide deck, but I'll tell you a little bit about him. He's a professor of psychological medicine at the Oxford University Hospital, also president of the Academy of Consultation Liaison Psychiatry in the US, and vice president of the European Association of Psychosomatic Medicine. So that's a great CV and background to talk to us today about post-COVID. Thank you.
Thank you very much. Can you see my slides?
We can, thank you.
Good, excellent. Right, thank you so much for inviting me. I think maybe I'm here for a couple of main reasons. One of them, which is I've had a career-long interest in fatigue and the treatment of fatigue. But the other one is that I helped to set up our post-COVID clinic in Oxford, which is based in the respiratory department, but which is multidisciplinary. And so I've had some clinical experience of the kind of patients that we're seeing, which I'm going to share with you. Given I'm giving the first talk in the meeting, I think it might be important that we at least try and agree what we're talking about. Not entirely straightforward. NICE in the UK has offered us some definitions, and as you'll see, there's acute ongoing, but it's post-COVID-19 at the bottom that we're concerned about here. And this is setting a time of 12 weeks. It doesn't specify any kind of severity, it just says signs and symptoms. And it does say not explained by another diagnosis. So this may not be universally accepted, but we're working on people who have significant symptoms 3 months after an apparent infection, although those are not always documented. Now, I already heard this mentioned. I'm going to intersperse my talk with some takeaway messages. And one of them is, it's been a tough time for academics, I can say as one. They've been stuck in their bedrooms. So what have they done? They've done a lot of internet surveys, and that can give us some clues, but it's absolutely hopeless at giving us any kind of prevalence estimates. And so because we never quite know who the denominator is, it's just the people that clicked on the questionnaire. So please beware of this deluge of poor quality research with unclear denominators. There is some better research, as you heard, coming down the track. So we all know about acute COVID. Who gets so-called long COVID or becomes a long hauler or post-COVID syndrome? Everything I say is based on what's published, interpreted through clinical experience. None of these are solid fact because this is an evolving area of understanding. But we're probably thinking of 5 to 10% of patients at 3 months have some kind of severity of symptoms and disability. Many more may have lesser symptoms and lesser disability. They tend to be older, predominance of females, and premorbid vulnerability, asthma, possibly depression. In Oxford, as in many other UK centres, we've set up a multidisciplinary clinic. And it started off seeing people had been admitted to hospital, but under pressure from primary care, it now sees, and in fact, the majority of patients are referrals from primary care. As you can see, consistent with the NICE recommendation, it has a range of disciplines in a one-stop shop multidisciplinary clinic. And we also have a virtual multidisciplinary team where we can bring in cardiology, neurology, and so on when needed. This has been a very interesting development. I think this is how medicine should be practiced. But of course, it's on short-term funding and long-term funding is promised, but who knows? So let's start with a case. There's a range of types of people and symptoms, but if it was to be a common case, that would be a GP referral. And most of curiously, the more complex patients tend to be the GP referrals, not the hospital discharges. So woman in her 30s, 40, teacher, small children, had a COVID-like illness about 6 months ago, wasn't tested, so we have to take it on the symptoms, and is now presenting to the clinic with disabling fatigue, that she says is made worse when she does things, widespread aches and pains, short of breath, and feeling of heaviness in the chest, and generally very anxious about her illness and about what's going to happen, and has not been back to work since she became ill. So there's a wide range of presentations, but this would be a common type of presentation. And as you'll see, the symptoms that she presents are the same as the ones that come out in surveys. So chest pain, shortness of breath, sometimes cough, aches and pains, and the most common and often most disabling symptom, fatigue. The other thing you'll notice from this diagram is there are a lot of symptoms, and I should say that's a short list compared to some of the things you'll see if you look on the web. So we're dealing with a large number of symptoms, with certain ones core to this presentation. I think importantly for our talk today, it's not just symptoms, it's function and particularly work. This is data just from 100 patients seen in the post-COVID clinics in Oxford and Cardiff. And as you'll see, more than half are not back at full-time work 6 months after infection, and a quarter have not gone back to work at all. This is mainly hospitalized patients. So in the non-hospitalized patients, the figures may even be higher. So that's the presentation that we're dealing with. What do we know about the causes? And my takeaway message for causes is that it's very easy to find oneself talking about post-COVID syndrome as if it's a thing like lung cancer or whatever. And I don't think it's just a presentation. So we must allow for the fact that it'll be heterogeneous, and we must be very wary about thinking about a single cause. And in fact, the clinical experience is that causation is complex. So I'm just going to run through potential causal factors on the basis of our clinical experience as biological, psychological, and social. So the thing that everyone thinks about is organ damage, and clearly there is frequently some damage to lungs. Our experience is that tends not to progress and usually tends to resolve. People do have acute abnormalities in kidneys, heart, possibly brain. But again, what we're finding as to follow up, the relevance of these abnormalities to people's presentation is often unclear, and often there isn't very much in the way of investigation abnormalities. People hypothesize there's some resetting of immune function. That remains a hypothesis. It's not apparent on normal testing. Patients often complain of tachycardia or postural blood pressure drops, and that's referred to as autonomic dysfunction. I don't think anyone really understands that. I think it's largely assumed to be something that will be reversible, but it's a physiological abnormality. And then, of course, this has often been a serious illness, and as the consequence is the way people have coped with it. So if they've gone from running marathons to lying in bed, that's going to have profound effects on their physiology and their muscle mass. Some people become very preoccupied with their breathing, very anxious with their breathing, maybe overbreathe, and that, of course, can produce biochemical changes and make people feel unwell. So there are a range of biological factors, and the specific evidence of organ damage is present in some people, but it is not the majority. At least not the majority is the cause of the symptoms. And one of the things I see written a lot, I wanted to, and second takeaway message is these people have a lot of symptoms often, may have 20, 30 symptoms. Multi-symptom illness does not mean multi-system pathology. So people talk about systems related to the heart, the lung, the brain. That doesn't mean that those organs are all diseased. It just means the patient has multiple symptoms. So let's move on to the psychological factors. And what's very striking in some of our patients is what you might call health anxiety. They're very focused on bodily symptoms. They're worried, understandably, what they might mean, particularly focused on breathing and experience of being breathless. Anxiety is prevalent in this population. A third to a half of patients have significant anxiety. And because of that fearfulness, they may avoid going out, and they may spend a lot of time seeking information about their condition because it's known to be a little mysterious, and they may seek a lot of medical care, and we'll come back to that. I think I and my colleagues think that social factors have an influence in shaping these presentations and the concern about symptoms. So here's an article by a well-known journalist in a well-known newspaper. And as you can see, he says that long COVID could mean lifelong COVID. The effects can be horrible. There's damage in the lung, heart, and brain, and we should all fear lasting consequences. So if you're of somewhat vulnerable disposition and you're feeling unwell and you don't know much about your illness, that is likely to make you more concerned and is not conducive to a positive approach to recovery. And inevitably, as a feature of the modern world, there are a lot of online groups, been even more important in this pandemic. Great benefit to many patients who feel worried about their symptoms and feel maybe they're the only one to be able to share those experiences and get some support. Potentially downside, as we've seen with the chronic fatigue and ME groups, who are also moving into this space to some degree, is the people that recover tend to leave, and you end up over time with the poor prognosis people who have a rather pessimistic view of the illness that they transfer to other people. So I'm not sure that all the support groups have been entirely helpful in encouraging the patients to take a positive approach. And of course, our old friends, doctors, are sometimes unhelpful here. This is a quotation from an immunologist that was reported in Nature. Their physicians don't believe them, and so they get psych referrals. So, it's not really real. You're sent to psychiatry. And his mission is to tell the people they have a real disease and what's causing it. And of course, that's another noble mission, but it can lead to excessive investigation, often investigation in multiple specialties over a period of time, which isn't necessarily helpful to the patient, and indeed can entrench the patient in worries that they have a disease, and again, distract them from the task of rehabilitation. So we don't know the causes, so please accept that what I've said is based on clinical experience and a smattering of evidence. But we think probably, certainly for the primary care patients, a biopsychosocial perspective, these different factors interplaying in different ways gets more and more relevant as the patient's illness and disability gets more chronic. So we're dealing with a heterogeneous and complex syndrome. What do we know about treatment? And here another takeaway message in working in the clinic is some of my colleagues feel that they need to keep a completely open mind on this condition. It's a new illness. Anything could be going on, so they need to do as many tests as possible. Whereas the opposing approach is actually, we don't know, but most of this looks pretty familiar. This is anxiety, it's chronic fatigue. We know how to treat those. We know about rehabilitation. Let's just be pragmatic. And I think one of the real challenges for managing this condition is somehow to keep that balance and not to go too far in over investigation and not to get too complacent that we know what's going on. It's a challenge. So the basic management that we would do in the clinic, and this is good management for anything really, is that the patients often come to the clinic, as they do with these kinds of illness, feeling not believed, feeling that maybe people are accusing them of making up their symptoms. No one's really taken an interest. And so spending some time listening to and showing you believe their experience is really first base. And if you don't do that, it's hard to get much further, to be honest. So that's a crucial starting point. I think the physicians have to manage the patient's uncertainty and their own uncertainty in deciding how many avenues to go down with possibilities and tests and how much to be pragmatic. We must remember it's heterogeneous, and we do find treatable conditions. About 10% have major depression. A significant number have new onset or exacerbation of asthma. We occasionally find hypothyroidism. So there are simple things to treat that one can find and treat. But I think what's really important is that as far as we know, most people improve. And so to give an overall positive message, rather than this is a very worrying, alarming condition that we don't understand and we don't know what's going to happen to you. And then the approach for most people is a gentle, slow return to activity. And at this point, some of you will be noticing there are some similarities here with approaches to many other illnesses, chronic fatigue syndrome, post-Lyme, post-minor head injury, all these things. And indeed there are, and it's tempting to see COVID as chronic fatigue syndrome with a cough. But I think that's a little bit dangerous to make just facile comparisons, but there certainly are some similarities. And so we don't have any randomized trials of treatment in post-COVID yet, because we haven't had time to have them done, but we have got randomized trials in these related conditions. So this is the trial that I did with colleagues about 10 years ago in chronic fatigue syndrome. And basically different treatments were tested. You can see here SMC, standard medical care, GET is graded exercise, APT is pacing, living within your limits, and CBT, CBT. So that basically they fall into the rehabilitative treatments, those that encourage people with care to gradually build on what they can do and not worry too much about the consequences of that. That's the bottom two, and the top two are the ones, the more conservative ones, just medical care or live within your limits. And you could see there at 52 weeks in this trial, there was a clear greater reduction in fatigue, perhaps paradoxically, of those that had the more active rehabilitation, and similar greater physical function in those that had the more active rehabilitation. And this idea of just pacing, just accepting your limits, is no better and possibly actually slightly worse than nothing than medical care. So that has been, again, as some of you may know, immensely controversial, because some of the patient groups are very against this. They feel it's harmful, it's not validating their illness. And so that leads to some potential difficulties for us in helping patients. But I think at the moment, if you've found and treated the obvious things you can treat, the best approach to post-COVID is accepting it'll take time and doing what I might call psychologically informed rehabilitation, explicitly dealing with worries, but helping them very gently return to activity. So if rehabilitation is at the moment our best hope, what are the challenges in providing that to our patients? Well, the obvious challenge is there aren't many rehabilitation multidisciplinary teams, as you could see a picture of there. They're being set up certainly in some places in the UK with short-term funding, as we have in Oxford, but it's patchy. The National Health Service in the UK isn't generally good. It's good at acute illness. It's not quite so good at rehabilitation. And the complicating factor is that NICE, who is the authority that recommends treatments, is potentially in a contrary position. They've done provisional guidelines on the management of post-COVID, which are good guidelines. I think they're not very specific, but they're very sound. But they're also doing guidelines on ME, chronic fatigue syndrome, which in their current form, they're being revised in the light of feedback, are saying you shouldn't have rehabilitation and graded exercise. So I don't know how that's going to play out, but that may complicate the provision of treatment for post-COVID patients. So what you really want to know is, okay, there's all this stuff, it's very complicated, and we rehabilitate. How well are people going to do? How many are going to end up, from the Swiss Re perspective, of having chronic disability and chronic work disability? And that's the one thing, of course, we don't know, because it hasn't been around long enough. But I think our experiences to date, that most patients do improve. It may be slow, we may be talking months rather than weeks, but with some advice, a bit of follow-up, most people do improve. So as far as we can see, that approach of getting people to have a sound understanding and not worry too much and work on rehabilitation is helpful. In the absence of really good data, physicians usually fall back, as you know, on the rule of thirds. So my guess would be about a third of these people won't do so well, about a third will do very well, and about a third will be somewhere between the two. And so if we say we've got 5% and we apply the rule of thirds, a guess would be something like 1% of these people may have some long-term disability. That is a guess, and it will depend on the care people get. But given the number of people with COVID, that could potentially be quite a lot of people. Sorry, my slides. There we go. So I want to provide another case study. This is an unusual case study because this one is in the public domain. This is Paul Garner, who's a professor of medicine at the University of Liverpool, and he's actually blogged in the BMJ his initial onset of long COVID and now his recovery, and it's probably worth reading. So he had a COVID-like illness. He was very symptomatic and disabled. He couldn't work. He describes it very well. And then he actually, he was becoming to believe he had ME, a chronic, possibly lifelong illness. And then he had contact with someone expert in rehabilitation of chronic fatigue syndrome, and he recovered quite quickly with a different approach of rehabilitation. So we don't want to argue too far from single cases, but it's such a high-profile example. It's quite interesting and one you can read about. Oops. So apologies for that. So just to summarize, those are my take-home messages. Beware of the poor quality research. Don't assume post-COVID is a thing. Just because they've got a lot of symptoms doesn't necessarily mean there's a lot wrong with them. We need this open mind of balancing. It could be all sorts of things with, we need to be pragmatic. There are similarities with other illnesses like chronic fatigue syndrome. Probably the best treatment is psychologically informed rehabilitation. At the moment, that may change. And from the insurer's point of view, I suspect there is likely to be long-term disability, and the precise numbers and severity, I'm afraid, remain to be seen. Those are three things that are probably worth looking at. The NICE guidance. There's a very recent sensible paper from a respiratory clinic by Sykes in lung, and Paul Garner's essays in the BMJ for a patient perspective. Thank you very much.
Thank you, Professor Sharpe. That's incredibly helpful. We have lots of questions, as you might imagine. So I'll start going through some of those. One question I had actually was whether you noticed any marked differences in the kind of patients that you saw that rooted from being followed up after discharge from admissions with COVID versus the referrals that you had from the community.
Yes, that may change over time, but quite a striking difference. The patients who have been in hospital tend to be older and even elderly. At their follow-up at 3 months, they often have some respiratory symptoms. They may have had some deconditioning. They've been in ITU, but they're relatively simple. That's what they've got. The ones we're getting from primary care, these are averages, on average are much more complicated with much more anxiety, depression, complex backgrounds mixed in. So that may just be an artifact of current referral patterns, and it may be the ones that seem most complex the GPs are referring, and we'll see how it evolves over time. But it has been a striking observation in the clinic, yes.
Interesting. Another question we had was around determining the veracity of reported symptoms. So you have this issue of belief having an impact on prognosis versus kind of whether there's any manipulation of symptoms. What's your experience of that?
Well, that's a complex area, isn't it? And it applies to all of medicine. I think one's more likely to see that whatever the illness, if people stand to gain or lose, on an insurance policy or whatever, leaving the army or whatever. I think at this stage in the game, at the relatively early stage, I think if there is an excess symptom presentation, it's driven more by fear and anxiety, and possibly to convince the doctors, but mainly by fear and anxiety, rather than any attempt to manipulate. I think as any illness, as you know, any illness gets chronic and people stand to gain a large payout, whatever, then people may obviously emphasize their symptoms. We're not seeing that at the moment.
And thank you. And another question from the floor is regarding the impact of the long COVID clinic work on rehospitalisation. Do you have any feel for whether it's managed to reduce that, or whether it's a separate issue?
Well, in Oxford, thankfully, we didn't have we had a moderate number. We didn't have a massive number of hospitalised cases. And the majority of people now being seen in our clinic are primary care referrals. It's hard to know. One of the things we have found that we're trying to do with the clinic is prevent the multiple referrals. So when I was saying that people get referred to multiple specialties, and that isn't just within the clinic, people are rattling around the hospital, as you can imagine, from cardiology to neurology to rheumatology. And I think one benefit of having a post-COVID clinic is you can try and pull them in and keep a handle on that. And so, we have a cardiologist will join virtually in our MDT, but the patients don't all have to go to cardiology. So I think we are containing the healthcare use and hopefully the adverse effects of all those opinions on the patient.
Excellent, thank you. One question was regarding whether there are any imaging studies that might link to factors in the fatigue elements of long COVID or wider. Are you aware of any imaging studies on that topic?
Do you know, if we go into the literature on chronic fatigue syndrome and other fatigue states, there are thousands of studies of all sorts of things, and there certainly are imaging studies. I'm not aware of anything that's giving us a generally accepted answer in either condition. But whatever your hypothesis, you will find a study, and some of those may turn out to be right, but at the moment they're not accepted. The main imaging abnormalities are just chest X-ray and chest CT, where you generally see resolving fibrosis, and that's the main abnormalities that we see.
One last question before we move on to our next speaker is regarding the change in the NICE guidelines, and I'm wondering whether that has any impact on our ability to manage this patient group.
Gosh, well, that's an interesting, highly political, moving target there. The NICE guidance, existing NICE guidance for chronic fatigue syndrome, ME, advocated rehabilitation in the form of CBT graded exercise. The revision of the guidance, which has been very driven by patient groups who feel strongly about this, was going to be very different. That's been out to consultation. I know several Royal Colleges have pushed back very hard indeed on that, and it's being considered, and that will come out in March. On the positive side, at the moment, the post-COVID NICE guidance is very, very sensible, very pragmatic, and advocates rehabilitation. So I think there's lots to play out there. What will happen with the chronic fatigue ME ones? What will happen with the NICE ones? But I think we just have to have this rehabilitation because it's the only thing we've got apart from time.
Absolutely, that's wonderful. Thank you so much for taking the time to speak to us today. That's very kind of you. Thank you.
Great pleasure. Thank you very much.